All right, hello and welcome everyone to the 2023 PI Conference. We will get started in just a minute. My name is Alyssa Creamer and I'm the Senior Director of Education and Community Services at IDF, and I will be your host for this afternoon's Ask the Expert Pediatrics session. Today, our audience will get the chance to have their own questions answered pertaining to pediatric immunology. A few housekeeping rules for today's discussion. Please remember that everyone's treatment and condition are unique. The information presented during this session is not medical advice, and nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Remember to always seek the advice of your own physician or other qualified health provider with questions concerning a medical condition. The focus of this session is on the pediatric population, so please be mindful of that demographic when typing in your questions. Please avoid questions specific to a brand of medication or specific to an individual or individual provider. And please avoid sharing stories or seeking advice that's highly specific to your unique health journey. This includes sharing any diagnostic numbers or test results. So without further ado, I'm excited to introduce our expert of the hour, Dr. Kate Sullivan. Dr. Sullivan trained at UCSF and Johns Hopkins and has been at the Children's Hospital of Philadelphia since 1993. She's the Division Chief of Allergy Immunology and oversees one of the largest North American clinics for inborn errors of immunity. She is a past president of the Clinical Immunology Society and has served on the Basic and Clinical Immunology Committee of the Quad AI and the Quad AI Board. She chairs USIDNet, the North American Registry for Patients with Primary Immune Deficiencies, and is a past chair of the IUIS Committee on Inborn Errors of Immunity. She co-edits STEAM's textbook on immune deficiencies. Her basic science research interests include understanding inflammation and the mechanism for regulating gene expression in inflammatory diseases. Her clinical interests include the study of patients with DiGeorge syndrome, chromosome 22q 11.2 deletion syndrome, variables related to outcomes of patients with primary immunodeficiencies, and developing diagnostic methods using advanced technologies. Thank you for joining us, Dr. Sullivan.
It's my pleasure. I hope everyone is having a terrific meeting so far.
All right, Dr. Sullivan, let's jump in. Someone is asking, my toddler has had many ear infections and tubes are being recommended. How do I know that tubes will help and he doesn't actually need a PI workup? I have a family member with CVID.
Well, having a lot of ear infections certainly is a sign of immune deficiency. And so when you're in the range of 8 to 10 ear infections, that's the time to think about a workup for an immune deficiency. But I want to say that doesn't mean the tubes won't help. So tubes help kids in the general population with normal immune systems, but they also help immune deficient people. And so they're not mutually exclusive paths to take, but I would say for little kids who are in the range of kind of 8 to 10 ear infections, that's about the time I think it's appropriate to think of a workup, or if it's 5 to 6 ear infections, but 2 pneumonias. So I add up different sites to get to the point where I think it's reasonable to think about a workup.
Thank you. All right, someone is asking if their infant received an abnormal newborn screening test for SCID, but their further workup revealed that all was fine. Should they still see an immunologist in a few years? Could this mean that a different PI might develop later on?
That's a really good question. So remember, we've only been doing newborn screening for SCID depends on the state you're in, but kind of on average for about 5 to 8 years. In general, what we say is that if you have a positive newborn screen, which means the T cells are low, but the subsequent workup says, nope, the T cells look great, that it was probably something revolving around the time of delivery, and we don't think it portends anything happening down the road. Now, you asked the question in a specific way. You said, should I go back to my immunologist? And that's really hard to answer. I typically, after I've seen the kids at a year of age and everything looks normal, I typically discharge them from my clinic. But I know there are other immunologists that will see them back a few more times to make sure there isn't something that kind of sneaks in the back door. So different immunologists have different practice, but I think we would all agree, as best as we know right now, if the flow cytometric workup that you have done after a newborn screen looks fabulous, then we don't think you have to worry about anything.
Great, thank you. How can you differentiate between an allergy issue and an immune issue? How do I know whether my child needs to see an allergist or an immunologist?
Yeah, that's also a thorny one. So I think the practice of allergy and the practice of immunology have actually kind of grown apart over the years because allergy has just different medications than they used to. But the reason it's still joint training is when the patients walk in the door, you can't always know if it's allergies. So people who have a lot of allergies get a lot of sinus infections. People who have an immune deficiency get a lot of sinus infections. So the patient walking in the door can look exactly the same. So the good news is that all allergists in the United States are also trained in immunology. So that's not exactly true in the opposite direction. For example, I did not train in allergy, but all allergists in the United States, if they're board certified, did also train in immunology. So you'll be in good hands if you get to a specialist.
Let's see. Next, how important is genetic evidence to confirm the diagnosis of PI? Is a lack of genetic evidence, this person completed whole exome gene sequencing without finding any known genetic variations connected to any specific PI. Is that challenging to get a diagnosis?
We're at this kind of funny point in the US, and what's happening in our country isn't exactly the same thing that's happening in Europe, in Asia. But in the US, presume that's where you're listening from, in the US, many, even most diagnoses at this point are based on genetics, but not all. I'm just going to give you an example. So among patients who have what we have long classified as common variable immune deficiency, the definition is having a low IgG plus a low IgA or IgM and poor responses to vaccines. So among people who fulfill those criteria, we only find a gene in about 30%. Does that mean there's 100 more genes we need to find that explain the other 70%? Does it mean we need better technology to find the other 70%, or the other 70% actually got to have common variable in a different way? We don't really know. So common variable is kind of the best example where we don't always find a gene and we know that going into it. I'm going to compare that with another diagnosis, chronic granulomatous disease. So in chronic granulomatous disease, the definition is abnormal reactive oxygen species. There's a special lab that you get. So again, we have a definition that we apply clinically. In that setting, we find the gene about 90% of the time. And if we don't find it, we're kind of worried because we think, well, in that 10%, we think we know what genes they should be. So those are kind of two examples. SCID would be another example, severe combined immunodeficiency, where we expect to find a gene and we kind of get worried if we've missed the diagnosis if we don't. So I'm going to summarize what I just said as sort of a take home. In pediatrics, we rely very heavily on genetics. And for most patients, we get genetics and we expect to get an answer from genetics. If we don't, doesn't mean we still have to treat the patient. So we still have to help them. And we do our best to use lab studies to get them a descriptor diagnosis to help us move forward with treatment. But the standard of care in the US for pediatrics is largely to get genetic testing. It's a different landscape in adults because many adults have common variable and there we don't always get a gene. And so it's a little bit different. I think the practice is still evolving for the care of adult immune deficient patients. And I know many adult immunologists, I guess we're all adults right now, many immunologists who care for adults don't always get genetic testing.
Mm-hmm.
So I hope that helps.
Yeah, that made sense to me. Thank you, Dr. Sullivan. This individual's son is 7 years old and has CVID. He has been on IVIG for 5 years. His genetic testing shows he has a TACI mutation, so they're wondering if there's any hope for a cure via gene therapy or something similar in the future.
So TASI is what we consider a risk factor. So lots of folks on the planet carry TASI variants, but don't have common variable. Having a TASI variant increases the likelihood that you'll get common variable. So that's actually not what you asked, but I just want to make that point. It's a subtle difference, but it's in our minds, it's definitely a difference. Okay, so you have a TASI gene, but your real question is there gene therapy down the pike? We've heard about it for different diagnoses. Where's it at for common variable? And is anyone doing it for TASI? So specifically for TASI, I don't think anyone's even doing it in a test tube. But since these questions are meant to be more broadly applicable than just one person, let me say that I think the time for gene therapy is actually kind of at that magic moment. So I think the technology is at a point where it can be broadly applied to a lot of different diagnoses. I think the issue is that right now it is ridiculously expensive, like in the range of 1 to 2 million per treatment. I'm not sure that's really sustainable. And so I think as a society, we have to figure out, not just for PI, but for all diseases where gene therapy is being proposed as a curative therapy, how do we grapple with that, and who's the right candidate to get gene therapy? So that was super long-winded. I'm just going to come back to TASI. As far as I know, no one is pursuing gene therapy for TASI deficiency. And in part, that is based on the fact that we don't think TASI is like a critical deficit that causes common variable. It's just like one more little chink in the wheel that sort of gets you to the point of having common variable. But in part, it's because there are over 500 specific genetic etiologies of PI. And as you might imagine, there aren't 500 labs that are trying to pursue gene therapy for each one of those genes. And so it is going to take a little time, but the technology is poised to be really transformative. The issues that we're facing are more related to healthcare delivery, insurance, things like that.
Great. All right. Thank you, Dr. Sullivan. All right. So when an infant who's just over 1 year old ends up with septic joint and rhabdomyolysis with a cause related to MRSA, should this rare and serious of an infection be worked up for an immune response issue?
Well, they could have invited other immunologists to do this Q&A, but I'm the one that's here. So I'm going to say yes. Here is my big perspective. So first of all, I'm a pediatrician. Second of all, I work at a tertiary care center. And third of all, I am way into genetics. Can you tell? So I think kids in the ICU that are very sick, babies in the NICU that are very sick, I think they all deserve a genetic evaluation. Are you going to find an answer for everyone? No. Studies have shown it's in the range of 20%. But for those 20%, it makes a big difference. You find them, you treat them, and hopefully you prevent them from getting something else pretty awful. So 20% to me, I'm okay with that. I think it's okay that 80% of the time we're not going to find anything. So I have advocated at my hospital that we should be doing genetic testing for all of the sick kids in the ICU and the NICU. So far, we're only doing it in the NICU, but I think that practice will get more traction as we find and help more kids. That's the name of the game, right? We want to help these kids and make sure they don't get sick again.
Thank you. All right, this individual says their child had their TLR tested after they express that when this child is sick, they don't feel like you can tell, or that they don't have any sort of response. And they had a reduced response in TLRs 2 to 8, and they have CVID. How important are TLRs at this time?
Well, we all want our TLRs. Let me just take a small detour here and explain what they are, so everyone else can appreciate why I'm enthusiastic about my own personal TLRs. So the TLR stands for toll-like receptor. They are our early warning system. So a bacteria lands on my tongue. Believe it or not, my tongue recognizes that bacteria because I have toll-like receptors, and it sends out a tiny little wave of cytokines to say, neutrophils, come on down, eat up this bacteria, it's a problem. So these TLRs are the early warning system that call in the troops, and the troops for bacteria are neutrophils. So very important. People that lack toll-like receptors do get terrible bacterial infections, and people who lack toll-like receptors often don't make a lot of fever. They can make some fever, but they don't make a lot of fever. And that is what it sounds like led to this diagnosis. Now, here's the dirty little secret. So toll-like receptor assays, super artificial, right? It's a test tube and they're using fake bacteria. So you can have abnormal toll-like receptor function in that assay if you're sick, right? Because the cells are already halfway down the pike, so they can't really muster anything more. So if you're sick, the results are often low. If something about the cells in your blood are unbalanced, because some cells make more TLR responses, some cells make less. So if the cell numbers are unbalanced, you can have low toll-like receptor responses. And then the last piece to this is that toll-like receptor deficient people don't have common variable. So I'm going to say that there is an answer, but the answer isn't the toll-like receptors themselves. The answer is something that is secondarily leading them to be low and causing common variable. Sorry, I left out a key part there.
That's okay. I think this next question kind of alludes to kind of what you've been talking about, and says, immunologists interpret the exact same data very differently within this field. Families are told that immunology is an art as well as a science. And this is often very extremely difficult for pediatric families to understand. So what guidance would you offer a family in this position?
It is pretty terrible, right? I've been doing immunology for 30 years and I can still wrangle over an individual result. So does it mean one person's wrong and one person's right? No, it's just kind of the shading on the interpretation. I think as long as those lab abnormalities are being respected and the patient is being treated, kind of the adjectives that you use and the way you talk about it can be very different and all be correct. So I see that pretty frequently. I get second and third opinions, and I always try and make it clear I'm saying this from my own lens. It doesn't mean the other person's wrong. We can all be right, just saying it slightly differently. So I hear you. The diagnostic odyssey can be really frustrating. And the fact that the language can be different from person to person. The interpretations can be different from person to person. I hear you. I'm not sure I want to fix it though. And here's why. I think that having all of those lenses on a patient is actually kind of valuable. So I work in this crazy multidisciplinary clinic called the DIRT Clinic for Dysregulated Immune Response Team. And so it's a rheumatologist, a hematologist, an immunologist, and an ID person. So we all look at the same patient. We go into the room, we all look at the same labs. And when we come out, we can say very different things. And so the reason we have this clinic is because we know it is frustrating for people. And so we step out of the room to have our arguments, our debates, our discussions, and then we go back in with a unified description for the family. And we do that because we know it is super frustrating to hear different things from different people. And it's not that the ID person has convinced the rheumatologist that they're right and the rheumatologist is wrong. It's just that we want to give a consistent message. We all usually are kind of saying the same thing. It's just people are bringing their own perspectives and viewing it in their own way. So I hear you that it's frustrating, but I think there's actually benefit for having that diversity from patients if you can navigate those waters. And I do appreciate that part's difficult.
Thank you. Many children with intellectual disabilities and autism struggle greatly with getting IG infusions due to their aversion to needles or having to stay in one place for way too long. In your experience, what do you think is the best way to help them get their infusions? What kind of supports are available to them?
Yeah, I use a range of options, and none of them work in everybody. So I'll just since it's quite a range, I'm just going to super briefly describe them just so that you've got some sense. And they're not just for kids with autism, they're for wiggly 2-year-olds, they're for, Everyone can have a meltdown on any given day. So they're sort of broadly useful. So for toddlers that are good sleepers, I sometimes say to the families, just give it a try, go in at night, put on the LMX cream that numbs the skin, and see if you can do it when they're sleeping, and just see if you can avoid the whole tumultuous experience altogether. So for heavy sleepers, that's actually a pretty good solution. I don't want to introduce any stress into anyone's lives. So some other options, I don't know if you've heard of these things called buzzy bees. So they're sort of acupressure. So you put them on and they vibrate wildly. They're actually, if you weren't using them for a purpose, you would find them very annoying. But I think that's actually part of it. And then the idea is because of this acupressure phenomenon, you actually don't feel the needle very much. For kids where it's not so much the actual sting of the needle, it's actually the needle phobia, which can be a huge part of it. Really the best, so I have worked very intermittently with a woman who does cognitive behavioral therapy. What's that? So cognitive behavioral therapy is introducing, so the best example is if you have a fear of bridges, you first stand on a brick, and then you stand on two bricks, and then finally you walk across like an itty bitty bridge, and then you start walking over. So that's the concept behind cognitive behavioral therapy. And while I have not done it justice in any way, shape, or form, you get the idea. You gradually sort of get people accustomed to it. Cognitive behavioral therapy can take some different conformations, but it actually has the highest success rate of any therapy, including drugs, for anxiety, phobias, things like that. So you can try some different techniques. You may want to get help from a child therapist. So try some different techniques that kind of invoke that model of cognitive behavioral therapy if needle phobia is a big thing. And, you know, child life specialists are astonishing in the ways they come at it. They use dolls. They've got all kinds of things. It takes patience. It does take time. It's not instantaneous. Every now and then someone will say, well, can't I just give my child Valium? You can. I mean, it's legal. It just seems not very nice, actually. So, but there have been kids where the behavior was so extreme and it just kept ratcheting up, then honestly, we did do it. So I would say once a year tops for me. But, you know, sometimes the situation is dire enough that you do have to go down that road. So that's kind of my range.
Thank you. Do you know if there is a connection between having a PI diagnosis as well as mast cell activation syndrome diagnosis?
Yeah, this comes up a lot, actually more on the adult side than the pediatric side. As far as we know, no. But we understand mast cell activation disorder really badly. So as far as we know, there's no connection, but with the caveat that we have a limited understanding of what that disorder is.
Right. How common are autoimmune diseases along with CVID? Are they typically only tested for when there are symptoms of disease, or is surveillance testing typically done?
Thank you for asking that question. That's actually a fabulous question. So autoimmunity occurs in half of adults with common variable. Actually a little bit higher in kids, but in adults with common variable where we have better data, half of the adults have autoimmune disease. Do we do surveillance? No, I don't know that that's right, but we don't do surveillance. And the reason is that the most common autoimmune diseases in common variable don't have great autoantibodies. So the most common are autoimmune cytopenias, inflammatory bowel disease, enteropathy, endocrinopathies. So the endocrinopathies, in other settings, we do surveillance, but it's not common practice for common variable because each individual autoimmune disease, not common. So you'd be testing a ton of people to maybe find one or two. So it's not common practice. I don't know that that's right though, but I'm glad you asked that question. So really, I think we're still refining our surveillance strategies, and that's one of the weak points for common variable for sure.
All right, we do have somebody in the Q&A box asking, how do you use LMX cream?
Oh, I hope you know about LMX cream, but you might know it under a previous iteration as IMLA cream. So it's a lidocaine cream. LMX cream is stronger though, so I tend to use it. So IMLA cream or LMX cream, it's it's a numbing cream. And so you put it on under some kind of occlusion because it has to sit there for a while. And then depending on whether it's IMLA or LMX, the skin is numbed down to about a centimeter. So IMLA, a little bit less, but you get it's pretty numb. I've had it on. You can't feel very much with those creams.
Thank you for educating us. Yeah, I feel like LMX is something everyone should know about.
Yes, it's fabulous. I agree.
Okay, somebody else is asking, oh, this is a follow-up from the individual whose infant had a severe MRSA and joint infection. All of their genetic tests are negative. So what type of other testing should be done to evaluate the effectiveness of their immune system?
So with the caveats that I said before, I'm a big believer in genetics. I would say you've probably had the best testing that you could have had. I presume someone somewhere along the way looked at antibodies, looked at neutrophils. So if the basics have been done and the genetics are negative, then we just say, we're going to watch you like a hawk, but as best as we can tell, your immune system is intact. And it was something else that drove this horrific infection. And it does really sound horrific. And that happens, right? There are non-immune deficient patients, non-immune deficient people walking around on the street who get tragic, horrific infections. We know it happens.
All right, somebody else is asking about the connection between SIBO and treatment for SIBO and PI.
Um, I'm going to answer it in the opposite direction because I think that might be what you mean. So immune deficient patients do have an increased risk of SIBO. For those who don't know what SIBO is, it's a bacterial overgrowth of the small intestine. So small intestine bacterial overgrowth. So it happens for reasons we don't understand. It happens in people who have kind of funky motility that's not optimized. It happens in immune deficient people. And for weird reasons, it happens in people that have had a lot of antibiotics, which feels wrong since the treatment is antibiotics. So SIBO happens a good bit in immune deficient patients. The treatment is pretty variable. The treatment is usually rifamycin, which is a kind of peculiar antibiotic that doesn't have a lot of other uses, but is used for SIBO. But people cook up other antibiotic schemes, and the monitoring is usually a breath test that measures, actually, I forget what it measures. I think it measures hydrogen. And so, it does happen once someone has had SIBO, even if they've been effectively treated and it's gone into remission, they are at much higher risk than the general population of getting it again. So we always monitor people. So we don't exactly understand why immune deficient people are more at risk, except we know being immune deficient means that your colonization is not the same as someone else's. And that colonization is important for preventing this crazy overgrowth of bacteria. So I hope that made sense.
Thank you. All right, someone is saying their child has had strep constantly since starting school. Should I explore having their tonsils removed or a PI workup?
None of those answers is wrong. Here is one tiny tidbit though. So people can carry strep. I forget the exact number, but strep carriage in the back of the throat is not that uncommon. And so if someone is doing repeated strep tests and they're always coming back positive and the person isn't even really symptomatic, or their symptoms are the same every single day, then I start to wonder if it's strep carriage, not acute infection. So that wasn't your question, but always worth remembering. If I see someone who's had 12 to 15 strep cultures and they're all positive, then, you really don't get that many strep throats, even if you're immune deficient. So then I start to wonder about strep carriage. So let's say someone has had 6 strep throats. That's actually a lot of strep throats. It is worth thinking about immune deficiency. It's also worth thinking about the tonsillar architecture. So the tonsils, if you look at, no one ever looks at their tonsils, but if you choose to look in the mirror at your tonsils, you'll notice that they have a very irregular edge. So they're sort of like the surface of a golf ball where they have little divots in them. And so the divots can be deeper, they can be shallower, but they harbor bacteria, and the super deep ones can harbor stones, and the stones get coated with bacteria. So you can keep reseeding. And so reseeding, RESEED, And so those are people who benefit from a tonsillectomy. You just need to get rid of the reservoir that keeps causing the reinfection. So if it seems clear that it's reinfection, there are periods of good health, the strep cultures are negative, and then it's back, then it's definitely worth thinking about a tonsillectomy. And again, even if you're immune deficient, it's still worth thinking about a tonsillectomy. Would I do a workup for an immune deficiency in someone with recurrent strep throat? Sure, absolutely.
Great, thank you. All right, so why do some kids have CVID, get on IG replacement therapy and do great and they don't have infections or anything autoimmune, but some kids have CVID, get on IG therapy and seem to get hit with infections and other autoimmune stuff constantly? What's going on?
Yeah, it's not just kids. So in common variable, half of the folks are going to get immunoglobulin, maybe an antibiotic here and there, and have a life that is essentially normal. And the other half are going to really be plagued, sometimes with infections, sometimes with autoimmune disease, sometimes with chronic lung disease. And it can be in the same family. It can be two kids with common variable in the same family. So it doesn't seem like exposures are really driving it. It's not necessarily genetics. When people have looked at the genetics and compared the two, they're a little different, but not very different. And so it's not entirely clear. There is this notion that your immune system is like a conveyor belt. And as the conveyor belt goes along, you sort of chunk on different exposures. And that really colors what happens down the road. Even if we can't name the thing, our immune system is very much impacted by not just the acute infections that we get, the rhinovirus that we had last year, the strep throat that we had this year, but also impacted by our general environment, how much pollution you've had, how much stress is in your life. Stress is a big driver of immune suppression. So there's a lot that we can't control. And we know even among people who are genetically identical and who have pretty comparable exposures in the same family, you'd think roughly comparable, they can have super different outcomes. So I'm really just, you will probably have noticed, I'm just validating your question. I don't have an answer and I don't think anyone does. So Charlotte Cunningham Rundles thinks about this all day, every day. And even trying to find biomarkers in the past that might predict the evolution, it has not been successful. So people are trying. It's not for lack of trying, but we do not have a good understanding of that.
Thank you. It seems adults with CVID are fatigued all of the time. Do children with CVID also have fatigue, or is this something that develops as they get older? Should I be on the lookout for this in my child as they age?
Yeah, important question for sure. I had clinic today. I hear it every clinic I hear this. And there is progress that I will just say a word about at the end, even though that wasn't your question. So among adults with common variable, about 20% have enough fatigue that it impacts their quality of life. So 20%, that's actually a fairly significant slice of the pie. Isabella Quinti in Italy tracked it over time, and the rates go up with age. So not very many 5, 6, 7-year-olds have fatigue, some, but not very many. And it goes up quite a bit in adolescence and then sort of plateaus in the 20% range throughout adulthood. Who are those people and why are they different? Again, Isabella Quinti has spent years looking at it. They do seem to be biologically a different set of common variable patients. So she's looked at a number of biomarkers, different outcomes, et cetera. They do seem to biologically be wired a little bit differently. So your question was, does it go up with age? And the short answer is yes. I realize I embellished quite a bit. But here is maybe the cause for hope. Because long COVID is thousands and thousands and thousands of people in the US, there's actually more research going on in terms of treatment for fatigue than ever before. So right now, the treatments that we have for fatigue are, and I'm not speaking to you because you wanted to know how to look out for it, but it's such a common question. It's such a common thing in common variable. I might as well just chat about it for a sec. So the treatments for the fatigue are almost like a physical therapy approach. So a gradual increase in your exercise until you hit tolerance. That's kind of time tested. I've done it for years. I think it helps. I don't think it's like a light switch. There's this crazy old-fashioned antiviral drug called amantadine. Probably no one on this call has heard it. It hasn't been prescribed for influenza, which is what it was developed for, I think, since the early 90s. But it has, in multiple sclerosis, it actually has a very beneficial effect on fatigue. And so I work with a woman who studies multiple sclerosis. So she said, well, just try it. Again, I have to say the effect is this much. So I have had patients respond, not everyone, but it's such a small thing to do. I think it's worth a try. And then the last thing that is used by the neurologist, not me, I've never prescribed it, is this drug called modafinil. And modafinil is used for narcolepsy. And I'm told that in other disease conditions where fatigue is common, that it is quite helpful. But if I get to that point, I do refer to a neurologist. I don't try and do it myself. So there are some treatments, but again, I think my hope is that all of this research on long COVID, where fatigue is a very disabling part of it, will have payoff for us, all of us on this call, in terms of management of fatigue, because I think it's pretty unsatisfying right now.
We will stay tuned for all of those studies to come out in the future, that is for sure. All right, someone is wondering if there's any research that you are aware of concerning treatments for chronic noroviral infections in patients with CVID.
I am giving a talk on Saturday about just that topic. So I don't know who you are, but thank you for tapping into an area that I have some enthusiasm for. So here is the crazy thing. And oh my God, I hope it doesn't affect you, because it is just sheer misery to have chronic norovirus. So for those of you who don't know about norovirus, it's a GI virus. And in immune deficient patients, instead of getting the virus and getting over it, which is what the general population does, it sort of hits the intestine and stays. And so people do get chronic diarrhea, can really be miserable. So in my time, I have used oral immunoglobulin, so the same stuff that you get IV, but you drink it. It's as bad as it sounds, but there you have it. Again, works like this much, not really magical. There is a drug that was developed for a different infection, but it has some activity against norovirus. Again, I think I've gotten a little traction in some patients with nitazoxanide, but it's not magical. But here is why I'm talking about it on Saturday. So it turns out that maybe not 100%, but most patients with common variable who have chronic norovirus respond to immunomodulation. What's that? It's actually kind of talking to the immune system and saying, you should calm down. And it seems like the immune system driving inflammation allows the perpetuation of norovirus. So I wouldn't say my success rate is 100%, but it's really high and dramatically higher than the other options. So thank you for asking that, because it seems crazy, right? Why would you immune suppress someone with a chronic virus? But it actually works really well. So definitely talk to your immunologist.
Our questions are just hitting on all of your favorite topics today, aren't they,
I
Dr.
know,
Sullivan?
norovirus, wow.
All right. Are there any jobs you say that you think kids, teens, or young adults with CVID should not be considering if they're on IG therapy?
I'm going to tell you what I tell my patients. So I have this crazy enrichment of people who have gone into healthcare in my clinic, and also people that have gone into law enforcement. It's really noticeable in my clinic. So it comes up a lot. And I have nurses in my clinic. I want to find a treatment that allows people to do the job they want to do. And so it's kind of my job. Now, I would be less than honest if I didn't tell you I have 2 patients with common variable who were floor nurses who got sick every winter because they were pediatric floor nurses and they got coughed on all the time. And they switched to surgical specialties because they thought they would get sick less, and they do get sick less. So having said that, they worked on the pediatric floors for years and years and were happy to do it. I think they just got tired of the sinus infections and feeling crummy in the winter, and they switched over to a surgical specialty where they get far fewer exposures. But I don't want to restrict anyone. I think it's my job to help people get to the career that they want. So I don't place restrictions, but that doesn't mean patients don't figure out for themselves that maybe a kid-free a kid-free career might be a little healthier.
All right, so this family says that our son has CVID and we have been offered immune testing for his siblings because of this. The other two are hardly ever sick and we've declined because they are healthy. Are there risks to not knowing, or is it safe to delay any testing in the absence of significant illness?
So across common variable, the likelihood of having a first degree relative, which by the way includes parents, having common variable. So one person in the family is diagnosed with common variable. What's the likelihood that siblings, parents, or offspring will have it? It's 10%. So not zero, but not super high. So I wouldn't argue with you if you didn't want testing. And I personally don't test prospectively. I tell families to call me if a sibling turns a hair. If anything happens, I want to know about it. But I don't test because are you going to test every year? Is that like for the next 50 years? So it's hard for me to imagine a model that involves testing every family member forever. Now, I am going to tell you that if I know someone has a genetic etiology, so someone, remember 20 to 30% of people with common variable, we actually know the gene that's driving it. If we know it in the proband, I will usually suggest that the siblings get tested if they're kids. Why is that? It's because I think some of these can have quite late onset. So I suggest it, but I don't mandate it, right? It has to be the family's decision. You don't want to force genetic testing on someone, but I do usually portray it in a positive way and encourage people to do it.
What are you recommending for kids with CVID or PI in general and masking at school?
Well, just this morning, I saw a boy who just stopped masking this month. I think that's fine. I have one patient who's still quarantined, masked. I'm not super comfortable because I think she's a little socially deprived, but she's happy with it. So hard for me to argue. I don't know what the right answer is. I also don't know what school's going to be like in September. Could COVID come back? It probably will, but will it come back like this? Then I don't care so much. So I think this is a very tricky time, and I think there's a lot of, I'm going to say politics. There's a lot of personal opinions. There's a lot of unknowns about whether masking is necessary. For the summer, I think people are pretty safe to go out without a mask.
All right. Oh, I know you're going to like this one, Dr. Sullivan. Can you talk about why people are calling primary immune deficiency IEI now?
Also in the talk I'm giving Saturday. So it's a little bit of a PR effort. So we've been talking a lot about infections today, right? We've been talking about who gets what infection, but notice there's been a thread of autoimmunity. So the idea behind inborn errors of immunity is to be a little bit more of a broad umbrella. So when doctors, I hate to blame doctors, but when doctors hear primary immune deficiency, they think infection and they forget the autoimmunity part. And so the idea is this inborn error of immunity is designed to be a slightly bigger umbrella so that everyone, including the folks with autoimmunity, can fit happily underneath. It's not catchy, right? Inborn error of immunity. I also have a friend who says, who wants to be called an error? So it's not perfect, but it was an effort to try and generate a little PR among medical people to get better recognition of the folks who maybe don't present with infection. Because I think it's hard, there's already this huge delay in making the diagnosis for people who present classically, for heaven's sakes. The people who present with autoimmune disease, it takes them even longer because people aren't thinking of it. So it was a little bit of an effort to try and get a little energy and education around what immune deficiencies or inborn errors of immunity look like. I'm not sure it's working, but it's caught on among immunologists anyway.
All right, we have time for just a couple more questions. So here's another one. How do you recommend an immunologist work with my child's pediatrician? Should I just always take my child to their immunologist, or is there a way for them to work together with a pediatrician because I can get in there faster?
Oh, I mean, you got to be practical, right? So if you can get into the pediatrician faster. So I see patients long distance. I'm used to working with pediatricians that are not necessarily in my back porch. So I think the communication is the crux of it. So the electronic medical records make it a lot easier. So particularly if your pediatrician and your immunologist are on the same platform, be it Epic or Cerner or Allscripts, it just makes it easier for communication. But that just having a pediatrician and an immunologist who are willing to talk, willing to communicate, that really smooths over a lot.
All right. Someone is asking if you have seen a connection between PI and POTS.
Oh, so for those of you who don't know POTS, it's postural orthostatic hypotension. I feel like I left something out there, but so I actually don't know of any data. I would say in my personal clinic, there's maybe a little bit of an enrichment of POTS. It's not a super strong signal, but I honestly haven't seen any data, which now that you mention it seems a bit odd, but I am not aware of any studies at all.
Right. This individual says that they have CVID and are considering having children one day. Would you recommend it being genetic tested for CVID?
In the end, it's your decision. I would recommend getting genetic testing for yourself before you have kids. Again, the likelihood that you're going to find something is in the range of 20 to 30%. It's not a foregone conclusion. But if you found a gene and it was one of the autosomal dominant conditions, and many of the genes that cause common variable are, that means you could pass it on to your child, not 100%, but you could. And so you might think about monitoring that child differently. You might not, but you might. So I would.
All right, good to know. All right, this is the last question I see, so we can kind of end on this. Someone is asking if there is something similar to LMX cream to use if they react to lidocaine with itchy and redness.
So the two creams that I know both have lidocaine. I don't know if there's a xylocaine version, so that's the other common numbing medicine that's used. I have not heard of a xylocaine-based numbing cream, but you might be able to just get the liquid xylocaine and just blob it on. The other thing to mention is it might not be the lidocaine that you or your child is allergic to. So lidocaine is not very allergenic at all. It's a teeny tiny molecule, but all of the stuff in the creams is allergenic. And so it might not be the lidocaine. And so maybe just changing brands and going with a different cream with different ingredients might get you over the hump there.
All right, I did lie. There is one more question that I see. So we do have time for this one, and then we will end it and let everyone get on to their next session. If a parent is hesitant about vaccines for a child because the child won't form correct antibodies, how or do you try to convince them otherwise? Do you insist that all kids get vaccinated no matter what?
Well, not sure why we're ending with such a loaded question there, but okay. So I never force anyone to get vaccinated. Having said that, I am a big believer in vaccines. They have unquestionably saved hundreds of thousands of lives. But as an example, I take care of a little population of patients here at CHOP that have a mitochondrial disease, and they often have metabolic problems after vaccine. So, not everyone can get a vaccine. So, it's hard to probe the function of the immune system in people who haven't been vaccinated. Really, really hard. And I do have colleagues who just won't do it. They will just say to patients, if you're not willing to get the vaccines, I'm not willing to pursue the workup, because it is really hard. I figure I have to meet the patient where they are. And so I'll do the best I can and acknowledge that there are limitations to what I can do, and do the best I can. Do I try to convince them? Yes, I bring out my chart showing patients, that have been saved by vaccines. We have a lot of educational materials here at CHOP because we're a vaccine education center. So I definitely pull out the resources that I have to try and convince them. But sometimes people have 10 years of vaccine hesitancy. I'm not going to change their mind. So I try and build some trust and, come back to the question if I can.
Great. All right. Well, thank you, Dr. Sullivan. Our time together has come to an end, and that's all the questions that I am seeing that you haven't already covered. So thank you again. It was an honor to have you join us today. And just a reminder to everyone who's out there in the audience, this session is just one of 39 unique learning opportunities that are being provided through our PI conference. So I hope you continue learning in today as we explore other critical topics for the PI community. And just thank you again, Dr. Sullivan, for your time.
My pleasure. Thank you, Alyssa. It's a genuine pleasure. And to all of the people in the audience, I hope you have an amazing meeting. Enjoy everything. Take care.
Yeah, take care, everyone.